If you've got any questions, you can type them in the column, or I think can you put your hand up or something. I will try and notice that you've done that because I'm flipping between two screens, or you can always ask at the end. There might be a slight technical glitch as I go from one presentation to another, because I'm really not very talented at doing this kind of thing, but hopefully it should be fairly smooth. So if we begin by looking at medicines in Parkinson's disease, right, there we go. Let's try this. So what we're going to do first of all is we're going to have a look and try and develop an awareness and understanding of all the different medications used in the management of the Parkinson's disease, and there's quite a lot of them. We'll have a look at important factors around drug administration and managing side effects, especially psychosis, hallucinations, and a few other issues. And I'm also going to look at what not to give people with Parkinson's, because it's something which crops up quite often. There are a number of different classes of medication given. Predominantly, we use dopaminergic agents like levodopa and dopamine agonists. There's some COMT inhibitors, and I'm going to go through all of these individually, so I'm just flicking through the list to begin with. Monoamine oxidase B inhibitors, anticholinergics, and a drug called Amantadine, which, for those of you who've been following the Russian response to COVID, you might have heard of. So, dopaminergic agents. Since the late 1960s, in 1969, they brought out Sinemet and Madapar for use with Parkinson's disease. We also have Stalevo, which is a combination of Sinemet and a COMT inhibitor, and a drug called Duodopa, which is a Sinemet gel given via a jejunostomy tube, which we do use, but it's incredibly expensive. Now, the benefits of using Sinemet is it is a precursor of dopamine, so the body will convert it to dopamine. But if you give it without an additive, such as carbidopa, then it gets converted very rapidly and can cause quite nasty side effects, in particular nausea and postural hypertension. So if you take levodopa with carbidopa, the carbidopa slows down the decarboxylation or the conversion to dopamine until it reaches the central nervous system, allowing you to give a lot lower doses of levodopa. As I say, it's the most effective drug for Parkinson's disease and has been since the late 1960s. And at the time, it was held as a miracle cure because it caused such a good impact on the Parkinson's symptoms across the board. What they didn't realize at the start is that if you take levodopa long term, you can get some quite nasty side effects, particularly dyskinesias and motor fluctuations. The patients who have been taking their levodopa for a period of time, basically the problem that you get is the longer you take the levodopa and the higher the dose, the greater the risk of side effects. And this is what they didn't realize at the offset. But what we've realized recently is a lot of it is to do with how long the patient has actually had the Parkinson's disease. So starting levodopa earlier or later, they will still get the side effects later on anyway, regardless. So it's quite important that if patients are symptomatic, that you don't hold off starting their medication for fear of longer term side effects. What happened was when I first started, the initial belief was if you took levodopa from the outset, say for about 6 or 7 years, these patients would develop dyskinesia. And if you held off giving them levodopa, you wouldn't have the same problem. What then happened was in about 2016, there was a study done in Africa of patients who had been drug naive and been diagnosed with Parkinson's disease for up to 10 years. And when they started them on levodopa, they discovered that they developed side effects within the first 1 or 2 years. And therefore, it sort of negates the idea it's the length of time you have levodopa. It's actually a combination of the length of time, but also the duration of the disease itself. So there's no point holding off on starting patients on levodopa therapy if they need some symptomatic treatment. The other issues you can get are wearing off and on-off phenomena, whereby initially when you start giving levodopa, then we normally give it 3 or 4 times a day, but as the duration of the disease continues, you find that the levodopa starts to wear off more rapidly, and therefore you often find that people with Parkinson's are taking their medications 5 or 6 or even 7 times a day, simply because that offsets the wearing off problem. It isn't such an issue now because we have COMT inhibitors and monoamine oxidase B inhibitors, but I'll talk about them in a minute. So there is a relatively high risk of dyskinesias. Probably about 60 or 70% of patients after 7 or 8 years will be dyskinetic when they take levodopa, and that isn't as I say, isn't as a factor of the amount of time they've been on it. It is the amount of time they've had their Parkinson's plus the fact they're taking levodopa. Okay. Some believe that a continuous infusion may be safer than pulsatile therapy, but the only continuous infusion we have at the moment is this drug Duodopa, which is a minimum of £29,000 per year per patient. So we don't use that very often, simply because it is so damn expensive. So we know that patients get these side effects, longer-term dyskinesias. They think it's due to excessive dopaminergic stimulation. Of course, patients with longer-term Parkinson's disease are making less and less of their own dopamine, and in some cases, they are virtually dopamine depleted in the central nervous system, and they are running on their medication. As he said, it is a later effect with higher doses, and it is rare in patients taking dopamine agonist therapy rather than levodopa therapy. The most common form of dyskinesia is peak dose dyskinesia. The patient takes their medication. After about an hour, the absorption reaches peak dose and the patients start to wriggle around in a dyskinetic fashion. But it can be biphasic, so the patients will take their medication. It will kick in, the dyskinesias will kick in at peak dose, but also when the medication is wearing off. So it can be reduced with dose reduction, but of course what you then are doing is reducing the patient's therapy. So you can, you're basically killing people to save Paul, basically. So we find that most patients actually prefer to be rather dyskinetic rather than akinetic and rigid. With dyskinesias, because they are involuntary, they tend not to bother the patients as much as people looking at them. So there are different preparations such as controlled release and standard release. Generally speaking, we only use standard release during the day and controlled release at night. There is a higher risk of dyskinesia and confusion and hallucinations if you use controlled release all the time, and the bioavailability is not as predictable. We also have dispersible forms in the form of dispersible Madopar, which some patients use to get their medication quickly. So particularly in the morning, they might get up in the morning, they'll take something like a Madopar normal release, but they'll take a dispersible as well, so it kicks in more quickly. And for some patients, high protein meals may affect the absorption because levodopa is an amino acid. If you take it with a high protein meal, they find that their medication doesn't work as well. But in the real world, that's not much of a problem in my experience. I've only had half a dozen patients or so over the years who've had a difficult issue with eating and taking their tablets at the same time. So the second most common forms of medications are what's called dopamine agonists. For want of a better word, they're fake dopamine. Originally, they came in 2 forms, the ergot-derived form and the non-ergot-derived forms. Now, the ergot-derived forms we rarely use now. They are far more attributable with quite undesirable side effects, and also they can cause problems with cardiac valves. So we've stopped using them now, and we only use the non-ergot derived forms of dopamine agonists. It's years since I've seen anybody prescribe an ergot. At the moment, we have 4 different types, which you may come across: pramipexole, ropinirole, and the reticotine transdermal patch, which is a newer drug and is really much quite popular with us because it's a lot easier to use than any oral medication. All of these come in once a day formulas, which also makes them a lot easier to use. The other drug we use is apomorphine, which is an injectable drug given either via rescue injections, via a penject, or via an infusion system. The benefits of dopamine agonists are that you do not have any absorption in delay because they don't compete with dietary amino acids. They have a longer half-life than levodopa, which means you can take them once a day, although they also come in 3 times a day form, apart from the patch. They can be used as monotherapy or adjunct therapy with levodopa. And it is believed because they are longer acting in the system, patients taking dopamine agonists are much less likely to develop dyskinesias and motor fluctuations. All of the manufacturers, when these drugs come out, said they may be neuroprotective, but I think they just say that. I have no faith in that whatsoever. Like levodopa, dopamine agonists unfortunately do come with common side effects. The most common is nausea and vomiting. Dizziness secondary to postural hypotension because it can lower blood pressure, although patients with Parkinson's can have postural hypotension as a symptom of their condition. So basically it's just exacerbating an underlying problem rather than causing it. Headache, drowsiness, somnolence, confusions, hallucinations, paranoia, peripheral edema, and impulse control issues. Has anybody come across these in Parkinson's with dopamine agonists? I can't see anybody apart from Sam. Those are there, just nod your head. Anybody heard of impulse control issues in Parkinson's disease? No? Good. They are quite rare, but if you ever start a patient on a dopamine agonist, you are by law required to warn them that they may get impulse control issues. I've had patients gamble tens of thousands of pounds once we put them on a dopamine agonist. And that can be quite problematical, but it is things like impulsive shopping, hypersexuality. I had a patient running around the countryside naked waving a sword once. So you do get some odd behavior which you really must warn the patients about, even though they are quite rare. I mean, basically we will say to the patients, this may happen, it probably won't, but if it does, can you please let us know before you get arrested? Basically is the premise with these patients, because they can be very problematical. So yeah, so we always document, if you ever start a patient on a dopamine agonist, document the patients you have warned them about impulse control issues, and also that they must contact you if there is a problem, and tell their partners as well. Oh, Rebecca, you've seen it. What was it? Gambling. If anybody wants to unmute themselves and talk, that's absolutely fine. I don't mind. It's a lot easier than typing. I can hear somebody typing. Oh, that's okay. Typing fervently in the background. Okay. Yeah. So it can happen. It is rare, but it can happen. So be aware of that. The other dopamine agonist tips. They are more inclined to make you slightly sleepy during the day. Okay, sorry, yeah, Becca's just put in hypersexuality and gambling, yeah, in 2 different patients. So it is out there, so be aware. So as I say, always warn the patients of the compulsion risk. Reduce if the patient becomes confused or hallucinating, but never stop abruptly unless you're using a like-for-like initiation. You can switch between dopamine agonists, which is what we tend to do if there is an impulse control issue, because they are not all the same. They have affinity for different receptors, so you can get a variation between them. Apomorphine, as we briefly mentioned, it's an injectable D1, D2 agonist. It's given via subcutaneous relief injection, rapid relief, or via an infusion pump when the patient's awake. Side effects, par for the course, nausea, vomiting, hypotension, as usual with an agonist, only it's far more potent. Has anybody seen these apomorphine pumps? Hi, Caitlin. And bye, Caitlin. Apparently she's just left. Okay. We do use them. We don't use them very often, but basically I wouldn't expect any of you to get involved with them. They're just too fiddly and complicated. Leave it to us. COMT inhibitors. These are a newer anti-Parkinson's type drugs. At the moment, there are 3 on the market: Entacapone, Opicapone, and Tolcapone. Entacapone has been around quite a while. Opicapone is a relatively new drug, and Tolcapone is a complex to use drug. For anybody who's heard of Stalevo, it's a combination of cinema and Entacapone. And what they do is basically prevent the breakdown of dopamine in the peripheral nervous system, therefore really increasing the half-life of your levodopa. So if you give a patient levodopa, body converts it to dopamine, and it's normally broken down peripherally by Catechol O-methyl transferase, and in the central nervous system by monoamine oxidase B. So if you have a Catechol O-methyl transferase or COMT inhibitor, then that means you can give levodopa and it will last slightly longer and saves you having to increase the dose. It is helpful for both early and fluctuating Parkinson's disease, and it's more particular for patients who fluctuate on and off during the day. So Entacapone used to be given as a 200 milligram tablet with each levodopa dose during the course of the day, but then they added it to Cinemet in the form of Stalevo and made it a lot easier to use, basically. So it increases on time. It does turn the urine reddish brown, and it can cause quite explosive diarrhea, which is the main side effect problem in about 1 in 10 patients. So we always warn of that. Tolcapone is a drug that it's a good COMT inhibitor, but we don't use it anymore because the patients have to have a blood test every fortnight for 6 months, and then every 4 weeks for a year after that. So we don't use that anymore. It's just too complex to monitor. Although it is a better drug than Entacapone. Opicapone is a once-a-day drug. It's the newest COMT inhibitor, literally came on formulary last year, and you just give it 1 hour before the last levodopa dose of the day. And from what I can see, it actually seems to work quite well. It works better than Entacapone anyway. The monoamine oxidase B inhibitors, which are the drugs which inhibit the breakdown of dopamine in the central nervous system, we currently have 3. Selegiline has been given since the early 1990s. Rizagiline is a later one which came out in the early 2000s, and sulfinamide is one which I don't even think we've got on formulary yet. It's a brand new drug. Can't see the point of it. We've already got 2, but it's probably more expensive, so we'll probably only come across Selegiline and Rizagiline. These drugs may be neuroprotective simply because they prevent the breakdown of dopamine in the central nervous system. Therefore, will probably enable patients to stay off medication longer, but they can be given as an adjunct to levodopa again. And like the COMT inhibitors, they make the levodopa last longer. So we can add them in, and they improve the patient's cover during the course of the day, but without having to increase the levodopa dose, and therefore reducing the risk of longer-term side effects a little. The other thing about monoamine oxidase inhibitors, you have to be careful as they can interact with tricyclics and SSRIs, and that of course can trigger a potential neuroleptic malignant syndrome, which of course is potentially fatal, so should really be avoided. So always check if you're going to start a monoamine that these patients aren't taking SSRIs or tricyclic antidepressants, because they commonly are. Anticholinergics, probably the oldest form of anti-Parkinson's medication, as they were initially used nearly 100 years ago. And what they do is they counteract the fact that with Parkinson's disease, the main issue is that the patients don't have enough dopamine, which balances the cholinergic activity in the muscles. This is a very simplistic explanation, I know, but it's probably the easiest way to describe it. So if you can't increase or even if you can increase the dopamine levels, you can also inhibit the cholinergic activity on the other side of that equation. And to do that, we use drugs like trihexyphenidyl predominantly. They can be very, very good for tremor, particularly with younger people, and also quite good for dystonia. But in terms of side effects, they are very problematical with older people. Confusion and hallucinations are very common, and they can also cause problems with urinary retention in particular. So certainly you can try them with younger people, try hexafenadil, keep the dose as low as possible, but I would avoid using it in older people. It's just too risky. Amantadine. Amantadine came out in the 1970s and was a drug used as an antiviral agent, and they found at the time that for some reason people with Parkinson's who got were dyskinetic and tried this drug, it seemed to improve the dyskinesias, although they don't know the exact mechanism. Once again, the side effects, autonomic, psychiatric, etc. Livedo reticularis is a skin condition which is fairly rare, but can happen with this drug. And interesting, the Russians are currently using it as a therapy for COVID because it's an antiviral. I don't know how good it is. I haven't got enough patients on it to make a judgment on that. But I don't know, I might pop a few more on just to see what happens. I mean, I had 6 patients in clinic this morning and 5 of them were COVID positive. So it's, when I say clinic, video, thankfully. But yeah, there's quite a lot of COVID out there in the community at the moment, I'm sure you're aware of. So the thing about Parkinson's medications, for those who've used them and for those who haven't, is that we can give a single patient a dopaminergic drug like Sinemet. They can have an agonist, they can have a COMT inhibitor, they can have a monoamine oxidase B inhibitor, and they can have amantadine all in one patient. So the complex regimes are fairly common. The average patient with Parkinson's takes between 2 and 3 different medications for their Parkinson's. So the things to remember are that these regimes are developed over a period of time. You know, most patients will start on one drug once a day or one drug 3 times a day, but we will add in their polypharmacy over a period of time, and we titrate and we balance these drugs for each patient literally on an individual basis. Patients are quite rightly very wary of hospitalization at the best of times because they are quite often not taking their medication for 3 or twice a day, and that's the problem. They also know their own medication regime, so they really should be listened to when they're admitted to the hospital if they are able to tell you what's going on. If they are admitted with sepsis, avoid making any changes until you treat the sepsis, until you treat the underlying problems, because sepsis will make Parkinson's symptoms worse regardless of what regime the patient is on. So always treat the sepsis first, and then we'll look at advice about whether or not they need to be reviewed for their medication. There is no such thing as a too high dose of levodopa in a patient who comes in on a, what may seem to be a lot of medication. I had a patient who was taking Sinemet 125 every hour while he was awake and came in. He was on about 2 grams of levodopa a day, and he came into A&E quite a few years ago, and one of the consultants decided he was taking too much medication and put him on controlled release 4 times a day. Yeah, it was virtually catastrophic for the patient. So if you're not sure, check with neurologists, look at the patient's medical history on eSearcher. These regimes have been developed over a period of time. That kind of very high, very frequent thing it's fairly rare these days because we've got COMT inhibitors and monoamine oxidase B, but they can still come in. We inherit patients from other areas on bizarre regimes, but do not change the medication unless you're really sure about what you're doing, because it can cause the patient and us no end of problems trying to sort it all out again. So psychosis in Parkinson's disease. People with Parkinson's disease often get psychosis. They also, in about 40% of cases, will have a degree of dementia, ranging from mild cognitive impairment to quite florid Parkinson's-related dementia. But it can be drug-induced or exacerbated. So if it's a relatively new onset, first thing you do if a patient is admitted with delirium is you exclude it by the usual sepsis screening, etc. If you're going to reduce drugs, do it in a stepwise fashion with what the patient had last reduced. So if the patient's had new Parkinson's medication added in, then that's the one you start reducing. If you're going to use antipsychotics, please use atypical ones at the smallest dose possible. And actually, unless you're really, really sure what you're doing, I would advise against it. I really would get some advice on that and monitor the response very, very closely. Drugs like rivastigmine and donepezil may be beneficial, but only rivastigmine is licensed for use in Parkinson's psychosis. Donepezil is not licensed for Parkinson's, although we do use it for some patients. So in terms of anti-PD drug management with psychosis, basically speaking, the drugs which cause more problems are at the top of the list. So if you start with anticholinergics, selegiline, amantadine, dopamine agonists, COMT inhibitors, and levodopa, take them out in that order. So if a patient comes in and they're on an anticholinergic and they're very psychotic, take the anticholinergic out, but reduce it slowly, or selegiline in that literal order. Thankfully, the least problematical drugs for psychosis in Parkinson's are levodopa, which I'm pleased about. Otherwise, that would make life even harder. So, contraindicated drugs in Parkinson's disease. Antiemetics. Prochlorperazine and metoclopramide are very potent dopamine antagonists. So if you give them to people with Parkinson's disease, they will have the dual effect of making their Parkinson's worse and also blocking their Parkinson's medication. So they should really be avoided. The drug of choice currently is, it was domperidone, but apparently you can only give domperidone for very short periods of time now, I've heard. So we would normally go with something like ondansetron or cyclizine. Would be the next drug of choice. In terms of antipsychotic medications, unless you really know what you're doing, I really wouldn't go there. Haloperidol is probably the most potent dopamine antagonist around and can cause severe side effect problems in people with Parkinson's disease, including neuroleptic malignant syndrome and possibly death, so they should be avoided. And actually, all of the antipsychotics on this list should be avoided if possible in people with Parkinson's disease. They all have very potent extrapyramidal side effects. At this point in time, if the patients are psychotic, if they are just hallucinating, we would use quetiapine. But if they have dementia and hallucinating, then I would look at using rivastigmine again. But once again, unless you know what you're doing, get the mental health team involved or the neurologists. Okay. So, final points. Hopefully you're all still with me. I can't see, apart from you two lovely chaps. Thank you. Parkinson's medication regimes are complex. Yeah. If a patient comes into the ward, it doesn't matter how complex their regime is. You have to try and fit to the patient and not to the ward drug round. Never stop any Parkinson's drugs abruptly, because that can cause severe problems. Hello, Mina. In psychosis, usually last in, first out. Never give haloperidol, metoclopramide, or prochlorperazine, but be wary of all antipsychotics and antihistamines. Avoid anything with extrapyramidal side effects. And if you are unsure, I'm sure you will, but please get advice. Any questions? Was that understandable?
That's really helpful, thank you.
Who was that?
Oh, Taylor.
Thank you. Okay, anybody got any questions? You can unmute, I don't mind. Somebody's unmuted, but they're not asking a question. That sounds like they're in a car.
That's me.
Is that you, Mina?
Yes, that's me.
Okay, so definitely no questions. Good. Okay, I'll see if I can set the other thing up now. Bear with me. This may take a couple of seconds. Okay, can we all see that? Can somebody just nod if they can see a red screen with practical management of acute Parkinson's inpatient on?
No, I can only see the, no, just the audience names and
Okay.
yourself. Yeah.
Oh, hang on a minute. I know
Yeah,
what
I can't see anything.
I know what I've done wrong. Hang on a minute. Oh, open share tray. Can we see that yet?
No.
No. Oh, don't do this to me, you horrible bloke.
I can see you.
How about now?
Yes.
Yeah, there we go.
Are we there? Are we there?
Mhm.
Okay, right, that's everybody back. I can see Mina as well. Hi, Mina.
Yeah.
Okay. I think this is a shorter presentation. You'll be relieved to hear. Obviously, for anybody working in hospital, in medicine, or even in surgery, you're going to find that you will come across people with Parkinson's disease with a number of issues coming into hospital. So what I've done here is we tried to put together a relatively short guide on how you would manage patients, or the things you have to be aware of when you're looking after patients coming in. Okay, trying changing screens. So the first question is, when patients come into hospital, do we get it right? If the patients are nil by mouth, then what do you do? Who do you ask? And some of the implications of getting it wrong. So a few years ago, we decided to do an audit of drug charts of, I think it was 74 patients or 72 patients admitted to the Conquest over the period of 1 year, to look at 3 aspects of their medication for Parkinson's. And the first thing we looked at was a prescription of Parkinson's drugs on admission to see if they were actually prescribed at all and correctly. And what we found that in 17 patients, so nearly a quarter of patients, the medication was not prescribed. This was all within the first 24 hours of their admission. So 25% of patients didn't even have their Parkinson's medication prescribed in the first 24 hours of their admission, which caused, as you can imagine, no end of problems. We also had a look at how many patients had some of their medications omitted or not given during the course of their admission. And what we found was 30 out of 72 patients actually missed a number of doses during the course of their admission, which is another thing which obviously we do try and avoid. And finally, on the topic of the contraindicated drugs, and these were predominantly haloperidol, metoclopramide, and stemetil, how many of these patients had contraindicated drugs prescribed on their drug chart? And it was actually a surprising number, although what we discovered at the time was that the patients who came in on the cardiac pathway, they had a pro forma that went on the drug chart, and that included metoclopramide. So a lot of these patients came in with cardiac problems and they were automatically prescribed metoclopramide on the drug chart. So we had to change that at the time. So on the basis of this, we then decided, I don't know if anybody remembers Dr. Dennison. I think he left last year. Does anybody remember Dr. Dennison? No, he was the head of teaching at the time, and said that what we'd have to do is do teaching sessions regularly to remind the clinical staff what they should and shouldn't do with medication for Parkinson's on the back of this audit that we did. So for patients coming in, I mean, there are basically 2 routes that you can take for giving patients who are nil by mouth their Parkinson's medication. You can either go using a nasogastric tube, or you can use a reticotine patch, but doing nothing is not an option. These patients, particularly patients on very high doses of Parkinson's medication, cannot arbitrarily have their medication stopped. And if you wonder why, in about 2004, when I'd only been here a couple of years, we had a patient admitted to AAU on a high dose of Parkinson's medication. And this was in the days before there was a reticotine patch for Parkinson's. And they tried to give this patient an NG tube, but they wouldn't tolerate it. So they just gave up, really. And between the Wednesday that the patient was admitted and the following Monday morning, the patient had no medication for their Parkinson's disease. Eventually, they got somebody from ITU to put a nasogastric tube in. And of course, because of refeeding syndrome, they decided to do a set of bloods, and every single blood came back as abnormal on the chart. And the patient died about 12 hours later from the restriction of their Parkinson's medication. And yeah, the coroner was really not very happy. So it is absolutely essential that patients do not have no medication for their Parkinson's. So the implications of getting it wrong, obviously an acute worsening of the condition for patients who don't have the medication. Quite often patients come in with swallow problems, chest infections and falls, etc. And these can get worse. Worst of all in this lovely day and age, a delayed discharge, which costs a lot more money. There was research done up at King's, and they discovered that patients with Parkinson's disease generally will spend between 4 and 7 days longer in hospital on average than patients without Parkinson's. And a lot of the reasons for that is because their medication was given incorrectly. And so their mobility, etc., was impaired. And so they had a chronic worsening of their condition as well. So it was harder to get them home and get them back to normal. And as I said, occasionally, worst case scenario, death. So if a patient comes in and you are struggling what to do, who do you ask? In descending order, me first, please, if you can. I am available via switchboard or because I have a mobile with me at home all the time. An on-call neurologist or a neurologist on site. At the moment at the Conquest, I think we only have one neurologist on site. We used to have 3, but 2 of them left, unfortunately. A doctor with a special interest. I think Dr. Wynne is the one who's taking the lead on Parkinson's for DME at the moment. If it is out of hours, there is an on-call neurologist at Hurstwood Park, 24 hours a day, 7 days a week. Or if you're really stuck, we have a lovely form on the pharmacy website. If you go onto the pharmacy site, the Conquest, we have a form on what to do for patients who come in with Parkinson's disease who are nil by mouth. Has anybody come across this before? No. Okay. That's probably why I'm here. We developed this in about 2012. It's been amended a couple of times since then. And I have to say, I think it's quite fussy. I think it's got a lot of wording on it. But it was decided by committee, and that's what happens when you decide something by committee. Everybody has to have their penny's worth. But the important things to point out, first off, it is crucial not to stop the medication. It's very, very important. And then if you follow the algorithm, can the patient swallow? Yes, give them the medication. No, NG tube. Okay, the first route of treatment for treating a patient who is nil by mouth with Parkinson's, cannot take the oral medication, is NG tube. Everybody goes straight for the retigotine patch, but it is not as good a treatment. Retigotine is more of a stopgap. The best thing you can do is follow the algorithm and give them their medication via nasogastric tube in the form of soluble Madapar. Okay, at the bottom of that, the same sheet of paper, if you find it on the pharmacy, is the conversion of all the Parkinson's medications into levodopa or the retigotine patch. And I know it looks quite wordy, but it is quite easy to understand. The other thing I'd like to draw your attention to is this box here, the yellow box. Whatever else is going on with the patient, if they can swallow their medication safely, put them back on their original regime as soon as possible. Okay. If you cannot get a nasogastric tube down, or the patient won't retain a nasogastric tube, then you can convert their levodopa or their dopamine agonist, because it's all over here, to a retigotine patch. And what you do is you give their daily total. So you take their daily total of levodopa and or other dopamine agonists, and you add them all together using these lovely switching formulas and turn it into a once a day patch dose. As I say, keep that on the patient until they can swallow again and then go back to what they were taking before. If they have to go home on the patch, so be it. You know, we've done the best we could under circumstances. The easiest way to convert, the other important thing, the vast majority of patients who come in will only be taking levodopa. This is the thing. It's very unusual for elderly, frail patients to take dopamine agonists anyway. So when they come in, they're on levodopa. The important bit is this bit right here at the bottom corner, which tells you how to convert levodopa into the patch. And that's the thing you'll use most. If you can get hold of me and ask me, that's fine. If you can't get hold of me, this is on the pharmacy website, on the intranet. And if you go onto pharmacy, scroll down, look for patients with treatment of patients with Parkinson's disease who are nil by mouth. It is there. It's very clear. It is a bit wordy, but I think it's quite easy to understand. Let that sink in. Okay. Any questions? Speechless. Yeah, I think the important thing to remember, the keynotes, patients come in on their regime, that they've been on that regime for a while for a reason, so try not to change it unless you have to. If the patient is acutely unwell, treat the underlying cause before you decide to make any changes to the medication. You can always ask me for advice. You know, I work Tuesday to Friday full time. Just go for me via switchboard. You can email me for advice. That's quite good. mike.scott7@nhs.net. You can get me via switchboard, and if you've got any queries, then please ask me. I'm always happy to help, and I will get back to you very rapidly if I'm working, because I know how important it can be for you and the patient to get it sorted. Okay.
Thank you, Mike.
Any more questions before I run off? Oh, you're welcome. Thank you, Farah. Okay. Any other questions about the nil by mouth thing? No. It's actually worth going on to the pharmacist website and seeing if you can find it. Just to make sure. I mean, I found it this morning, so it's definitely there. But you know, print it off and familiarise yourself with it, because it is very, very useful. I mean, if you want a basic rule of thumb, for every 50 milligrams of levodopa, you give the patient 1 milligram of patch. That's the abridged version. So you add up their total daily dose, and then just give them 1 milligram for every 50 milligrams of levodopa. Ignore the carbidopa, ignore the Stalevo, the Entacapone. It's just about the levodopa. That's all it's based on. Okay. Thank you, Nathan. Very kind of you to say so. Any other questions?
Thank you very much.
Okay, thank you.
Thank you.
Thanks, Mike.
Bye.
Bye all.
Thank you
Stay
very
safe
much.
out there. Take care of yourselves. Get vaccinated.
Thanks, Mike. Are you able to share the slides with us, if that's okay?
Do you want me to send them to you?
Yes, please.
Yeah, that's fairly straightforward. Yeah, I'll do that straight away.
Fantastic. Thank you very much. And I've finished recording this.
Did that make any sense? He said.
Yes, it did. Of course. It does. I'm listening, even though, you know.